Buddy, is this on? So welcome to our benefit benchmarking survey report. Thank you so much for everybody coming today. I really want to thank our staff for the effort. We had a great turnout, over 100 responses into the Philadelphia survey, over 5,000 nationally. We have JD Gustafson here from our partners at Milliman, who is going to go through the results. And then at the end, I'm going to spend a couple minutes and talk to you about ways to use the information in a productive way instead of just having data. For those of you that don't know who Pentra is or Alera Group, I'll just give you a slight overview. I am one of those lucky people in life that loves where I work. I love the people I'm with. I wake up every morning and I'm super fired up. And I'm really appreciative of everybody in our firm that put together today and had the whole effort in doing the survey results, because it lets us be better at what we do. So initial question for you today. Anybody ever been really passionate about something? Really passionate that they're looking around at what they do in their life or what's going on, and they recognize that there's a better way, and it might be hard to get there, but it's worth it. So a group of the leaders within Pentra and 24 other member firms across the country, boutique independent employee benefit consultants, got together in 2016 with that kind of energy and thought. And we built a new company. And what we were passionate about was the fact that we felt like employee benefit consulting was underachieving. There was a better way. And so we've built Alera Group. Pentra's one of the founding members. I was on the board of it. And it has a couple of core principles, one of which is that there's something great about an independent local consulting firm, and there's something great about a national consulting firm. In an independent consulting firm, you get entrepreneurship, you get flexibility, you get great access, you get immediate response, you get a willingness to say, we don't do that, but we're going to do that for you right now because it's the right thing to do. What they don't have is they don't have the scale for national resources in a world where you need compliance, in a world where you need technology, mobile apps, people doing mobile apps for their employees, people doing videos for their employees, massive compliance regulation. You need resources. So Pentra is about having the entrepreneurship and the boutique relationship with employee brokerage and having centers of excellence and access for administration, compliance, communication, design, and help with cost. So Alera Group was a new firm on January 1st, 2017. As of today, we're about $280 million in revenue. We're in the top 10 largest independent employee benefit consulting firms in the country. We're growing just short of 10% a year, and we're doing it by having new members join. So we don't buy people. We're looking for people to join that have expertise that can add to the value to our clients. And we have a couple of core principles. One is collaboration. So we're doing this by having a lot of the people that are in this room today are on work groups with other like-minded people throughout the country trying to better solve, how PBMs are taking advantage of our clients. What's the best way we can do this? How can we write a contract that's airtight so that you're not getting ripped off? Right? Anybody done a PBM analysis? We're saving $1,000 an employee per year. It's unbelievable. So shared resources, equity, entrepreneurship, client experience, and building together. That's what we're doing. We thank those of you that are our clients that participate in it. We're looking for feedback if we can do it better. One of our partnerships is with Milliman. We partner with Milliman for two specific reasons. They are the best, and we are a best-of-breed approach. Right? They have access to data that nobody else has access. They have 50 million lives in a healthcare database that the insurance companies buy. So when our clients get a renewal from their insurer with made-up numbers, right? Like, hey, this is what it would cost if we had no claims experience. And we go to Milliman and say, hey, we're going to give you a census. Can you tell us what it would actually cost if they have no claims experience? And they come back and say, oh, it's 20% less. And that lets us negotiate your plans better, because there's only one right answer. And the other thing is they're really an extension of us. So JD has some folks, Ty, who is doing a lot of our underwriting for our clients, and it really doesn't feel any different for us than the guy right next door in our office, which is what we look for. So I'm going to bring up JD and have him go over the results. Thanks, my man.
Thank you. So as Clint mentioned, my name is JD Gustafson. I'm with Milliman on the survey team at Milliman. Also have John Caniglia in the back, if you want to stand up for a quick second, John. So we'll be available afterwards, same with the Pentra team, to answer any deeper questions. But the format of today, we're going to go through a couple of overall questions. We're definitely going to go through the results of it, but we're also going to have some polling questions. First of all, because no one wants to sit up and talk or listen, more importantly, to actuarial type speak for an hour without some type of break. But it also gives me just a little bit of the flavor within the room of the size of companies, our employer groups in multiple states, and so we can hit on a couple different aspects as we're going through this. So first one is a warm-up question. So this might be the easiest or the hardest question of the day today, but if you could spend 15 minutes with any living person, who would it be? I'm not getting political, so there's Donald Trump up there. I put Carson Wentz. Maybe the question should have been, who should start this next weekend, Wentz or Foles? Because when I landed, that was like all the topic on the radio, so I love hearing that. So if you have a clicker, go ahead and answer that, and I'll go ahead and start the poll. And the responses are coming in just to make sure all the polling system is working. No wrong answer on this. So I'll let just a couple more responses come in, and we'll see what the verdict is. Okay. I'm not surprised by that. So definitely some Eagles fans in the room, but good. So everything's working. So we'll have a couple of these questions throughout, and we'll try to lighten it up some as we go through. But this is a little more specific, but it also just gets, not only from my perspective, but also just tells everyone else in the room what the tenure and benefits is, all the way from first year, so newbie, all the way to ready to retire. Okay, so 10 to 15 years is the clear winner on that. Have a little bit of everything, but there's definitely a lot of experience in the room, and that definitely helps as we're looking at historical stuff, but more importantly, as we go forward, there's definitely a lot of experience in the room to handle that. Another specific question to your specific employer group: how many of your company's employees are eligible for the benefits program? So it's just going to give us a little bit of a glimpse of what the size of the companies represented in this room are. Okay, and this is what I would have guessed, but it's also good to see because this is a benefits benchmarking survey. It's really designed for the mid-market. So there's definitely employer groups that are under 100 lives that take this survey, and then there's very, very large employer groups that take this survey. But really, that mid-market is really where this is geared towards. And we'll get into some of the numbers on how many mid-market companies we have nationwide and also in this area. And that's going to help when you benchmark, when you look at, okay, what do things look like on a national level? But more important, what do things look like here in Philadelphia? And even more important, within your industry and size of employer group. I think this is the last one of these questions. But the question here is, do you have employees located in multiple states? No, yes 2 to 3, or yes 4+. I'm going to get my timer going here so I don't go over. Wow. So I know this is an area where there's a lot of states here, but definitely a lot of employer groups with employees in 4+ states. And so usually it's 2 to 3 or the 4+. We're seeing less and less employer groups that are just, hey, we're in one state. Not that that's right, wrong, or indifferent, but that's just a trend that we're seeing as well, regardless of the size of group. So today's agenda, we're going to really focus on 2 questions. How do I align my company's benefits with others? You could also say, how do my benefits align with others? So we talked about national, we talked about state, local, and then once we have an idea on that, healthcare is just, it's moving, it's changing. How do we manage costs within the volatile market? So going through some ideas with that, and then Clint's going to wrap up with just how to apply a lot of the data and go more strategic within that, and certainly there can be a lot of follow-up after that. But that's really the agenda. Again, we'll break it up with some of the audience polling, so it's not just go, 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 but we'll definitely be respectful of your time. So just taking a quick step back and looking at the survey overall. So we're in probably the fourth quarter of the survey. The data was cut probably 2 or 3 weeks ago, I would imagine, and we're at 5,200 on a national basis. So that's just important from the standpoint of we want that number to continue to grow. Probably at the end of this year, this survey particular will have over 6,000 employer groups participating. So there's definitely a lot of depth there, and it's nationwide. But more importantly, looking at this area, because healthcare is different. When we're looking at Texas and we're looking at the Northeast, there's a huge difference there. So it's good for you as you have employees in different states to see what's going on in those states, but it's also a very good sample size here with 120 groups participating. And what I'd say is a very sincere thank you for filling out the survey. I know it takes time, but it's definitely beneficial for you, and we hope that that continues to. And from Pentra and Milliman's perspective, we want to keep growing that number so it continues to be of value as you continue to look at your strategy going forward within your employer-sponsored health plan. So just a couple quick numbers on the overall survey as it goes. And here are where there's more survey responses than others. So I want to say almost in every state we have survey responses. Alaska and Hawaii, not so much. So if you have employees out there, probably not going to be much info there, but you can see definitely big concentration on a lot of the Northeast and other states as well. So darker the state, more surveys we have within that. And as I mentioned, this year we'll probably be in the 6,000 area, but really in the next couple of years, want to continue to push that forward to the 10,000 mark and perhaps beyond that, just to give you more data and more ways to slice and dice that to make decisions within your company. Okay, so here's where we're going to get into a lot of the details of the actual survey and the results of it. So this is going to be within this local area, the plan prevalence. So what type of plans is the Philadelphia area seeing? And you can see it's led a lot by the high deductible health plan at 44%, and the PPOs are at 38%. And so the one thing that I'd say on this is we're seeing just on a national perspective that high deductible health plan really grow. So it's getting a bigger piece of the pie year in and year out as we do this. It used to be, depending on the area, of course, but a lot more on the PPO side. You'll see a little bit of HMO and POS represented here as well, but definitely these are the two main ones, and we're seeing this number grow. And one thing that will be very interesting going forward is as you continue to do the survey and we look at this area, take a look at this number to see how that changes as we're going forward, just to see what the market's doing and apply it back to your specific group. Number of plans offered, we have 26% with one plan, 30% with two, 33 with three plans, and 11% with four plans. So about 66% is within that. And we're really seeing that, that's not too surprising as you're looking to attract and retain talent, looking at the different plan offerings, looking at the different components within that. We're seeing definitely a lot of employers looking at multiple plans. So this is probably in step with what we're seeing on the nationwide level as well. I'm going to take a little bit of time on this slide just to explain what you're looking at. It's also a good reminder, say you have a couple things in front of you. One would be the healthcare report, similar type of slides on it, and then you have your individual ICR, and that's really where it gets specific to you. So you can look at that and compare where your benefits are to the Philadelphia market, and you can also compare it to the national. Those are the median numbers. Now that's only so much, but what I would definitely recommend is look at those as you're looking at the strategy going forward, but also contact the Pentra team. We'll demo one tool here going forward, but there's a lot of different tools that you can really refine that even more to go into, okay, what if I'm union, non-union? What if I want to look at manufacturing within the New York, New Jersey, and Pennsylvania area? So a lot of different ways that you can refine that and really be specific to your company and what your needs are going forward and what your competition is doing. So the burnt orange color here, the bars, that's going to be the national median. And we're going back to 2014. So we've seen that kind of click up. Really a big jump this year on 2018 versus 2017. So that's the first thing that I see when I look at this. But more specific, let's look at what's going on in the Philadelphia area within Pentra on all the respondents that took this particular survey. And we'll start off here. That is going to be the median. So that's at that 550 number. Bottom portion here, this a little bit lighter dotted line, that's going to be the 25th percentile. So 25% are at that level or below. And then this number up here, the 75th percentile, is on the higher level, so 25% would be at the 1,500 or higher. And so within this Northeast market, you're seeing very strong PPO deductibles. That's not a surprise for this area, but that'll be important as we go forward just to know the strength of that. It definitely does impact the premium when we look at that, but you can see even if this was still at the $1,000 area, it's still a very competitive median for the PPO. So that's just one thing to keep in mind. Very strong PPO plans, and this is in network. So that's how we're going to read or view these slides. We're going to go through a handful of these going forward as we go through the results. Is there any questions on reading the slides or anything like that that I can or need to clarify before we push forward on it? Yeah. It's going to be, so the national media is just everyone that took the survey, so employer groups that took the survey. So could, but probably not. So just the sponsor groups there. So co-insurance, there's not much happening on this slide. Nationally, it hasn't changed at the 20% level. Locally here, there's definitely some that are below that, but on a co-insurance basis, not really much going on there. As far as out-of-pocket max, the median is a little bit closer to the national median, and the national median hasn't changed. So again, the burnt orange is the national median. Let's look at these numbers here. 25th percentile is that 2,700 area, and the 75th percentile is at the 6,300 area. So we would project that this is going to probably continue to creep up. We saw the change from last year, so locally there was a change. Might not be to this aggressive of a level, so we're working with 2 years of data here. So I would anticipate that this goes up, but maybe not in that extreme of an increase there, but definitely seeing a little bit of shift and movement there with the out-of-pocket max on the PPO. Office visit copay, really kind of steady within this, so it's not a plan design change that many are making. And so national, it's stayed there at the $25 area, and the median in this market is at that area as well. So again, and I'm going to sound like a broken record, but it's great to look at this national info, but take a look at your own at the ICR and the Pentra team, and you can narrow this down further as well. So this is kind of everything just wrapped up. So on the left here, we have the Pentra Benefits Benchmarking Survey, so that line right there. And then we have the 2018 National. And looking at the first slide, we saw how strong of a PPO deductible this was. And when we take the value difference between what's going on locally here and then the value across the national basis, much stronger plans here, and we see that in the 15% area. A lot of that coming from the deductible. Not, there's definitely some changes in the RX copays, but a lot of that's coming from the actual deductible itself. So very strong plan designs here. It's almost night and day when you're looking at a different state like a Texas or something like that, but that's just something to take note of the strong plan designs here with the PPO. High deductible health plans, so we'll go into the other portion here where we saw most of the plan prevalence. Again, would anticipate this probably creeping up some, but maybe not to that degree because we're just working with 2 years of data here, and as we get more and more data as the years go on, that will impact that. But we're just looking at the change from last year to this year. Median level on that looks like it's right around the, I don't know if I can read it sideways, probably not quite to the $3,000 area, but here locally the median number is at 2,500. 25th percentile is at 2,000. The 75th percentile is at 3,000. So again, here still pretty competitive versus the national high deductible health plans with the lower deductible in network there. Co-insurance, as we saw on the PPO slide, there's not much moving within this, both on a national basis or here. Everything stayed pretty consistent as far as the co-insurance goes. Out-of-pocket max. So this is one area where the Philadelphia market really is kind of lock in step with the national median. Have not seen the change in the out-of-pocket max on the high deductible health plans. So we're at 5,000 median, 3,500 for the 25th, and 6,400 for the 75th percentile. But again, probably start to see that out-of-pocket max creep up there on the high deductible health plans on a national basis as we go forward. So looking at the same similar slide to the PPO when we just wrapped it all up. Again, 2018 Pentra Benefits Benchmarking Survey here on the left, national. So this number right here, the 15%, that's going back to the PPO that we saw in the earlier slide. So it's about 15% less rich than the PPO. We'll get to a slide that explains that a little bit more. Just wanted to point that out on the bottom there. So that's not comparing against each other. That's going back to the PPO on some of the slides that we saw before. But if you look, just as we're comparing high deductible health plan to high deductible health plan on the national basis, a little bit of a stronger deductible, and contribution is a little bit higher here as well. So that's another thing to take note of, just from the competitiveness of these plans and the overall offering. I made reference to it in the last slide, but this is the relative value of plan design. So if we put the PPO at 0, so that's what we're basing it off of, so we have a very strong PPO in this market. The national, again, it's about that 15% area, so national PPO is about 15% less rich. And then the high deductible health plan here it's almost lock in step with the national PPO, but those are the differences of the high deductible health plan versus that PPO that we looked at. So again, pretty strong benefits on both the high deductible side and the PPO side of things. I'll stop there. Is there any questions that you have so far? Feel free to yell them out. It definitely helps the process, and we can do our best to answer that. Dental. We don't show a lot on dental because not a lot moves on dental, but there's definitely some strategies that are being implemented on a national basis to just bring costs down. It's not as big of a piece of pie as the medical and the prescription, but there's still a lot that you could potentially do with dental. We'll definitely talk to the Pentra team on that, but really there's not much difference here at all, except a little bit on the annual max side on the dental plan. So we don't see a lot of changes within dental. Maybe on the West Coast you see a little bit more aggressive dental plans, but everywhere else it's pretty much the same. So we don't spend much time on it, but definitely wanted to bring it up because it is a portion of your expenses. So that's kind of the first section of the presentation, which is just going through the information. And again, look at your ICR, talk to the Pentra team. We'll be able to go through that in more detail and really refine specifics on that. But the rest of the time today, we're going to spend on really how do you manage the cost in a volatile market. So just some different ideas, some different things to look at, and then also some things that are going on nationwide that may or may not be happening here, or maybe things that you've heard about, but how do you get a grasp on it or maybe take advantage of it? That's something that we'll look at here in these slides. So this is the healthcare inflation. So this is national historical. First glance here, you're like, wow, that's pretty good because it's stabilized. Probably to do this more justice, we probably should have gone back, and we were actually talking about it this morning. I mean, it wasn't that long ago that numbers, the median would have been at the 10% area. And so while healthcare inflation has stabilized, so we're looking here at the 5% is the median, 0% would be the 25th percentile, 9% would be the 75th percentile. There's still 25% of companies getting a 9% or more on inflation, and that's after a lot of plan design changes. So the good news is, yeah, it's stabilized, but the bad news, if you look at GDP just on a whole, I mean, it's down here. I think there's a slide on here next that will go through that. And so this is a problem because it's taking more and more of your money, and it's taking more and more of the employees' money, and that's even after plan design changes. So this really isn't sustainable. And as we go through just, okay, here's where GDP is. Yeah, it's stabilized too. Maybe it might start kicking up some, but that's a huge difference. And so that's a problem that isn't easy to fix. But these are just some of the numbers behind it that a lot of employer groups are looking at and saying, okay, this isn't sustainable. I've made a lot of plan design changes. Every year it seems like we make some plan design changes. What else can we be doing? And that's where we have a lot of discussion points with the Pentra team and different clients, and really just kind of showing you what's going on within the national basis. To take that just one step further, although I've probably made the point and you feel it on a daily basis, if we just take a look at, okay, let's pull out a salary comparison. Let's look at a manufacturing industry. In 2008, the average salary was $37,490, and now it's $44,000 roughly. So yeah, salary's gone up some, but if you look at the employee contribution on that, that's gone up drastically. And if you take a look at the benefits package that's being offered, that's a big difference to go from 500 to 1,000. You see the different tiers there on the RX, and so definitely a lot has changed in the years after 2008. You saw inflation really hit a pretty high number, but it's just, again, it's not sustainable as you go forward. And so looking at some different ideas and what else is out there to help that. So final, after all plan design changes, we talked about nationally. Now let's talk locally here in the Philadelphia market. The 75th percentile is at 11%. So 25% of the local market had above an 11% increase, and that's after all the plan design changes. Median is at 7%, so a little bit higher than national. I know Philly is a higher cost area than some places, but there's a little bit of uptick there just locally compared to what's going on national. And then 2% would be the 25th percentile, and I believe 25th on the national was at 0%. So a little bit more inflation happening here locally, just to kind of build off of the last couple slides that we went through. So we've talked about all the different plan designs that are out there. Let's talk price now. So this is all comparing the total premium, and I'll take just a quick second here to go through how to read this. And so this blue, this light blue, is what the employer is contributing to the PPO. The darker blue is what the employee, this top number is the overall. Same thing with the orange, the lighter orange would be on a national basis employer, and this is national basis for employee. So that's on the PPO, and that's on the high deductible health plan. So you'll see we have richer benefits in the Philly area, and of course that's going to come with a little bit difference in cost. But when you look at the difference between this, it's almost right around the same percent of what the strength of benefits is. So we're definitely not saying that your costs are out of control or something. It's just that's what the market is, and there's very strong benefits and there's very rich benefit plan design. So better plans, but a little more cost than on the national basis, and same holds true on the high deductible health plan, just not as much of a difference within that. That's employee only, and this is going to be family. So same trend here, but that's just going to give you the numbers on what the employers are contributing on a family basis. And this slide is really just going to take a different way of looking at that and go through all the different tiers, but you'll see that the trend is really there. Sometimes you'll see just within a specific tier, one will be lower and the national will be higher, something like that. But in this case, it's pretty much congruent across the board on the cost on that. So, okay, so I know we just went through a lot of info, so we'll take a little bit of time for the audience poll. So if you still have your clickers, we'll take those out and we'll get through a couple of these questions. As we're doing that, I'll stop and ask if there's any questions on what we went through within the premium. Nope, okay. Okay, so this is where you could rate what you currently have. So just say on a scale 1 to 5, with 5 being the best, how would you rate your health plans today? Okay, so that's good to see. Some places you'll see more of the 2s and 3s. Definitely have some in the 3s here, and really that's kind of the trend that we've seen this year. So definitely some strong plans out there, and I would agree just from the data that we just went through. Definitely some very strong health plans, but it also shows that there's definitely always room for improvement. You know, we're talking cost right now, so there's always some different ideas that we can look at there. So within that, I'm going to demo one of the tools that Pentra has, and Clint did a great job of just explaining Milliman and our role with Pentra. We really see ourselves as an extension of Pentra's staff, and so this is one of the tools that Pentra has to look at your plan on a deeper level. And I logged into this like an hour ago, so it probably logged me out. So we'll see what functionality it will give me. I will try to log back in if it's not working. But wanted to go through this just as something, as we're talking about all of this, it's important to be looking at what's in front of you with your ICR, but really when you're developing a strategy going forward and looking at who you're competing against in the perspective of attracting and retaining talent, this is one of the tools that can give you a very clear, concise answer up front on, hey, how are we doing? How rich are our plans compared to who we want to compare to? And where are we at with both employee and employer cost? And I'll run through it and show you some different functionality of it. But more importantly, it's going to bring up possibly some questions or some ways that you want to improve, or maybe you have to peel the benefits back some from a cost perspective. It opens up to be like, okay, where do we take that, or where do we need to push to? And there's some other tools that can support that as well. We won't get into all that today, just in respect of time. But it's something that we've seen very, very useful for employer groups throughout the country. So first and foremost here, on the very left, we have benefit plan. So it's basically saying, how rich is my benefit plan? So this is dollar agency, sample agency, and sample company. So this is all sample data, but it's going to have the same functionality that you would have. And so it's saying, right now, this group is in the 35th percentile, and they're really below the 50th, and they're kind of in that least rich area. So if they wanted just to get to the 50th percentile, which that's showing, and it's kind of small, they would have to increase their benefits by 7%. Let's say they wanted to increase benefits to be in the top quarter, they'd have to increase their benefits by 19%. Or, say they want to just be in the bottom 25%, they could decrease their benefits by 5%. So this is something that can validate or maybe contradict a little bit of where you think you are in your benefit plan richness, and that's a sliding scale that the Pentra team, as they're sitting down with you, can go through that and then again talk about how do we get to those targets. Same thing is going to go on employee costs, are really kind of right in the middle point, but it shows you where you could adjust this as you compare and align with other companies to increase or decrease costs, and the same thing goes with the employer costs. So this is great when we're going against national data, but it can be a lot better when you go against what you specifically want to go up against. So if you're in Philadelphia and you're in manufacturing, it's probably going to make more sense if we look at Pennsylvania, or if we look at Pennsylvania, New Jersey, and New York. We look at industry. So there's different type of industries within this that you can go through and select, because it's going to be a lot more crucial as you refine that. So just do Pennsylvania, you do industry, manufacturing, you could do employee size, so the size matters as well. And then you could do from an organizational type, if there's union involved or it's nonprofit, so a lot of different things that you can do, and it probably locked me out, but I'll see if it can go. Just press go and it crunches the numbers again, and it shows you just that changed it a lot, because it matters where you are from location, and it matters what type of company you are. So I would definitely encourage you to kind of dig into this and go even further with what's called the CAP. It's a Comprehensive Assessment of Health Plans, which is just going to show you, all right, here's where our benefit plan is today. We need to increase benefits by 6%. Is that a deductible issue? Is that, so all those different things would be answered by some of the online tools that we have working with Pentra, really as an extension of their staff. Is there any questions on this tool, or how to utilize it, or how we typically see it used? Yeah. Yeah, correct. So right now we're on total. So all the benefits, like your long-term disability, your life insurance, we can just look by medical too. So let's say, hey, let's keep all the benefits, other benefits out. I just want to compare my medical plans. And you can see that actually dropped that sum. So guessing here, but they probably had some strong ancillary lines, but maybe not as strong on the medical. So this employer group dropped a little bit more when we changed it to just the medical. So you can really narrow down and refine by lines of coverage down here as well. Great question. Good. It's always good when technology works when you're in front of 75 people instead of having to log in and scramble. It's going to have John come up and tell jokes for a little bit. So again, this is just some of the screenshots within it. If you're interested in that or the CAP report, definitely let us know. All right, we'll get the poll questions back up here. And this is just as we start to look forward. So we kind of know where we are and we know where we have been, but let's look forward. And what is the most important objective for your benefits package as we look towards the end of this year and into next year? Is it productivity? Is it retention, attraction of employees, job satisfaction, cost that's always out there, or the proactive management of employees' health plan? So go ahead and take a second and respond to those, and we'll see what the group's thinking here. Okay. This has been definitely a trend of, I mean, this is tied, but we're looking at the retention and attraction of employees, and then we're looking at cost. Probably 2-3 years ago, cost was like number one, like very much, and then so we've kind of seen the attraction and retention of employees increase just because the job market is a little crazy right now. Unemployment's very, very low. I think, don't quote me on it, I think last I looked it's like 3.9%, and of course in some areas it's a lot stronger than that, so it's like almost scrambling to find employees, and one of the ways to do that is definitely through a great benefits program and overall wellness and happiness and everything that can be offered there. So also the proactive management of employees' health went up there as well. So that's not entirely surprising, but definitely a little bit of adjustment the past couple of years on just the cost issue. I mean, it's still very important, but we gotta attract and retain employees too. Okay, so now we're gonna shift just a little bit and say, okay, what's the strategy to combat the increase in healthcare? So we talked about inflation even in this market, and so what are we doing just as a group to go after that this year? So we have plan design changes or the implementation of a high deductible health plan. We have more cost sharing with employees, changing funding arrangement, additional emphasis on wellness, or move to a narrow network plan. I'll go ahead and start the poll. Does anyone have a guess on what's going to be number one? One? Okay. Ooh, another tie, but it's good. Yeah, so the plan design changes, so we're still seeing that. And then additional emphasis on wellness. Gordon, does that surprise you just from some of the discussions that you've had, or? Perfect. Awesome. So a little bit on more cost sharing with employees. Move to a narrow network plan. Did not get any votes there, and that's okay. So just want to see what's going on within this marketplace. So I'll take a very short period of time to talk about self-insurance. So I don't know within the room how many are self-insured or not. I would imagine a lot are self-insured, but some of the things that we'll talk about kind of has a basis within that, or one thing too, as we've done this survey year in and year out, we're seeing smaller and smaller and smaller groups going self-insured. So a couple years ago, it was really in that 500 plus. We saw a lot of activity within it. This year, I've seen not only just the data that's telling us, okay, smaller groups are going self-insured, but we get requests from maybe a 47 life group that's saying we want to look at self-insurance, not captive, but full out self-insurance. And so definitely not going to make blanket statements on whether you should or shouldn't be doing that, but that's what a lot of companies have done to look at costs. And so we'll go through this, just a hypothetical group of 353 employees. So there's the enrollment. And here's what it really looks like on the fully insured side. Here's where all the cost is going. So within this group, the total premium per employee per month was $848. And you see the claims cost is the same. The RX claims cost is the same, but where you start to see a lot of differences is, yeah, we got to add the stop loss premium in there most of the time. And then you see claims administration is a little bit different. broker consulting fee, and the PCORI fee, but you really don't have all the premium tax and some of the other fees. So just if everything else stayed the same from a claims perspective, from a just that stays the same, these things change, you're going to see a little bit of savings. So within that group, they would be looking at $237,000 of annual savings. So that's pretty significant. You can definitely go more aggressive to say, okay, well, what if you know, we're doing this and the claims costs go down, both on the medical and on the prescription. You could see something on an aggressive scenario up to $512,000 of annual savings. And so that looks really, really good, but we can't do an aggressive without doing conservative because, as you know, claims costs tend to bump up sometimes for various different reasons. But if we increase those two, you're looking at about $174,000 of additional cost. And so it's just something it's interesting to look at all of this to see, you know, just the different structure and where a lot of those savings come from. Anything that Pentra or we do on a more in-depth basis, we'll go through a lot more detail, but that just kind of shows the 30,000-foot view on that. And so I believe we're looking at the same group here. A bunch of lines here, but what this is showing is about 84% of the time, it's going to be more advantageous for this group to be self-insured. So that's those really good years. And this is the not so good years, but that's compared to the fully insured basis. And so for this group, that's what it looked like. And then you can have the discussion, knowing the facts, say, okay, do we go self-insured or do we stay fully insured? What do we do with the stop loss? How do we adjust that? And so a lot of different communication points within there, but it gives you kind of the facts to say, okay, this is a good decision or this is not a good decision based on a lot of different variables. Captive insurance is, it's another way of funding that I would say is growing, especially for some of the smaller groups, and smaller probably that 100 to 250 to 300 range, where if this is fully insured, we see there's where the deductible is, and basically the employee takes that and the carrier takes the rest. Self-insured employee, where we're using the same deductible there, employer is going to take a portion before it goes up to the reinsurance. The captive model takes a little bit of both, but it gives a little more transparency, it gives a little bit more freedom for the employer group. And so there's still some of that level there, but then it goes to the captive level before it goes to the reinsurance company. So a lot different structure. If you've looked at a captive before, or if you have interest, or you've looked at it and you said absolutely not, you know, that's okay. But certainly we can help you take a look at that from the Pentra perspective, or kind of get into a little more of the details of just the functionality of it. But really show this just to say there's that desire for some more transparency, a little more control, and we're seeing smaller groups go self-insured, so we're definitely seeing more of those small groups, maybe not taking the full step to self-insurance, but they're saying, we got to do something different. The captive can do it, but again, would suggest a pretty in-depth analysis to see, okay, how does it look first year, but how does it look in years after that, so you're able to make a good decision on that. Pharmacy, and here's some audience poll. These tend to be some of the more interesting audience polling questions just because there's a lot of stuff going on with pharmacy. I'm watching my time here. Got about 15 minutes left, and Gordon and Clint and I could probably stand up here and do a 3-hour presentation on pharmacy. They've probably done some breakouts on pharmacy, but there's just a lot going on within the industry there. But here's just kind of a quiz. Which state had the highest number of retail prescription drugs filled in 2016? So we have Texas, big state, New York, obviously a lot of people there, California, Florida, Pennsylvania. Which state had the highest number of retail prescription drugs filled in 2016? Okay. That is a great guess, because I would have guessed the exact same thing the first time that I saw this. Yeah, I mean, you think Florida, a lot of retirement and stuff, but it's California. So I'm not trying to trick anyone or be deceptive there, but it is California. 2016, we're talking rebates here. What rebates made up what percentage of prescription drug claims? So we have 2%, 7%, 10.3, 12, and 16. 16%. It's a big, big number. So again, first time I saw this, I did not guess 16%. So it's kind of a staggering number there.
You're not getting $100 per script rebate. It's not negotiated well.
Okay.
That's what the market will give you right now.
That's a good point. Great point. I think this is the last question on prescription, but what is a prescription drug expenditure difference? So the difference is the key word there. In the U.S. from 2014 to 2018. Those all look like huge numbers to me, just period. But this is just the difference. So we have 36.7 billion, 47.5, 52.4, 62.2, and 75.8. $62.2. So some very good guesses there. That's just the difference. That is a lot of money. There's a lot of money in that flow there, and we'll get to a slide there that talks about that. And this slide is really to Clint's point. I think it's just a repeat from one of the slides that we looked at in the self-insurance. But here's the medical claims portion, the RX claims portion that Clint was talking about. You know, there's ways to develop a strategy if you're self-insured to really be aggressive within that, and that can be a big difference on this overall premium line. And so a lot of different strategies behind that, a lot of different ways to look at that, but would definitely recommend a PBM analysis and getting aggressive within that. So that's just one function there to help save on costs. So I hope that most slides that we've gone through I've explained well and you can understand. I'll be upfront and honest, I'm not going to explain this very well. And it's an absolute mess. There's so many lines and dotted lines and numbers here. There's no way that I can sit up here and do this justice. And this is probably a simplified version. But all it's shown is a flow of goods and money within the prescription world. And there's a lot going on within here. And it's pretty easy to not know what's going on or potentially be taken advantage of, or not have the best deal out there. And that is real dollars. And so, again, I'm not going to explain this. We could spend the next 3 hours explaining this and going through different stuff, but we'll definitely look at the pharmacy as a way to be aggressive and look for savings and look for good strategies on how to attack that and improve the plans that you're able to offer your employees and cut on costs there. So any questions on this? Comments? It's Mm-hmm. Yeah. Yeah. Just like looking at your benefit plans in total and the comparison and the benchmarking on a year in and year out basis. You may have a great plan today, but that maybe in 2 or 3 years, that's no longer a great plan. It's really crucial here too to make sure that you're doing the proper maintenance and management of this portion of it going forward. Thanks, Gordon. So just a couple points, really going off of what Gordon and Clint had already talked about, but we're talking about just a couple things to look at from a PBM selection, and of course Pentra can help out with that, but we see a lot of that, and it's just a way that employers are taking advantage of that today. A couple points here. Just is the contract written in a way that allows for transparency. We're going to get into transparency in the overall process here, but definitely looking for that transparency and just making sure that you have a good agreement that that's not one-sided on something like that. Effective contracting. So I'd say at least every 2 years. Gordon just talked about every 1 year. So it's not something that you can just think you have something good today and hit autopilot, because things are definitely changing. And so looking at the renewal terms on that, any type of audit, procurement of it, and going through the invoice on that to make sure everything's going the way that it should within the contract is also very important. So we've talked a lot about price transparency, and there's other things that we could talk about today, whether it's reference-based pricing, whether it's narrow networks, even though no one said that they're going to move to a narrow network, but just other ideas. But one thing that we're just getting a lot of energy and a lot of push behind. And trust me, it's an uphill battle. But what we hear people talking about on a national basis, or what people are looking at, is just, look, we want price transparency. Wouldn't it be great if we bought healthcare kind of the way we buy everything else? So you have a willing seller and a willing buyer. Yeah, the seller is at a price that can make money, but it's not taking advantage, and the buyer can say, hey, you're going to get paid. It's going to be cash. It's going to be quick, and so it just feel like it's more of a smooth process. And so there is energy behind this topic, and the status quo is just saying, hey, look, we can't afford what we're typically doing, and the systems a lot of time end up winning. And so if we look at GDP, we look at the inflation. Again, it's not sustainable. So we got to do something. I like this slide just because it just shows how crazy some of this stuff is, and it's from Healthcare Blue Book, so it's something that you can look at online. I think this market is Oklahoma City, but it's saying, okay, let's take a look at some standard procedures. Let's look at this market, Oklahoma City, and say, what's the low price for those procedures? And then what's the high price? And look at this variance. I mean, over 1,000% for carpal tunnel. You're going from 1,200 to 14,000. And so if we just talked about, we don't buy anything else like we buy healthcare. So it's like going to a gas station and saying, okay, low end in Oklahoma City is $2.30 and the high end $16.44. Like, there's no way this gas station at $16.44 would be in business very long. But it also, you could almost add the perspective of, yeah, when you pull in, you know what the gas is costing. A lot of times when your employees go in for these common procedures, they don't know what the price is. And even if you ask, it's sometimes like pulling teeth to try to get something like that. So this is just pure craziness. So the average market variance is 715% just in one market. Yeah, there's some quite, you could say, well, some places might not be as good at care, but I mean, these are all good care organizations, and that's your market variance. So it's just, that's just, it would not work if we bought anything else that way. And so one of the things that I'm just citing it, but I think it's fmma.org or .com, but it's Free Medical Market Association. They are an association that tries to put willing buyers and willing sellers together to say, okay, for this knee surgery, it's going to cost this much. You can negotiate, or you can't negotiate. I mean, that's just what it is. But you can go to that center and you know what you're going to pay. The employer can pay cash, and it's something that works for the employer. Or even individuals could do something like that. Public entities could. Really, on the self-insured side would be from the employers. But it's going to be something that you can budget for. There's not going to be as much variance within the year. If something changes within the contract, that's void. But there's just different ways, and it is an uphill battle because you're going against a lot of entities that don't like this concept. But it's one of the things that's out there that's saying, okay, if we just knew what it would cost, we could send our employees to a great care organization, know what the cost is going to be. We could budget for something like that, and it can make a difference. Direct primary care is another thing that we're seeing, along with on-site clinics. On-site clinics we're not going to spend as much time talking about because it definitely depends on employer size, location, whether or not that works. But direct primary care is also something that's out there. So it's not a poll question, but I'll ask it. Has anyone looked at direct primary care or familiar with the concepts with it? Okay. So I don't go to the doctor often, but when I do, it seems like I'm in there, I'm rushed through. I see the actual doctor for 30 seconds, and I walk out of there with either go get this test done or here's a prescription. And so the thought out there too is that's kind of a broken system, because a lot of times you go get an MRI that's not needed or prescriptions that aren't needed. Not even touching on the opioid crisis or on insurance fraud and some of the stuff that goes on there. But the direct primary care is going to have a model that's the doctor is going to have fewer patients, more time with each patient, and better results. And so we're looking at these are just two companies, I think, MDVIP and Q Liance. It's going through some of the numbers of saying, okay, within this model, the direct primary care approach, you're going to have fewer admissions, fewer readmissions, fewer time in the hospital, fewer procedures. And so they're looking at dollars saved. I'm going to skip through this quick just because we're running a little low on time, but these next slides will explain it just a little bit better. Now, this is taken 100 employee group, looking at the admissions within there. And then Imagine MD is another direct primary care company, so that's where the info is coming from. But they're looking and saying, okay, if we just had 6.9 fewer admissions per year, and that's the average cost of an inpatient admission, we're saving $72,000. 100 life group, and that's real money. And so just a couple different ways to look at this. ER visit, same company that they're looking at here, $26,000 of savings. And so again, with a company of that size, that is definitely real money. So the overall, when you roll that up, it's less sick time, it's less savings for inpatient and ER type of visits. And so the whole point of it is the doctor will have less patients, spend more time with the patient, be more in tune with the health and the plans going forward, so that there's not as much of that kind of waste going on. So that's definitely something that's gaining traction. It's not, I wouldn't say it's super widespread where you hear of everyone's doing it in a certain area, but it's something that I think is gaining traction and does have some real impact. Clint, is there anything more that you'd say on that portion of it?
No, other than there is a exploding market. There's 30 different vendors. There's state regulation around it.
Yes, yep.
What's really interesting too is there's a demographic issue. So if you're hiring young people, they want online. They want it. They would love to have a doctor that's on the phone, and which isn't teledoc, right? This is actually somebody who's accountable for their overall health.
Yeah.
On an ongoing basis.
Yep.
But, we think it's really viable. We do everything from a database perspective. So if you have high urgent care usage, high emergency room usage, low primary care usage, which is a simple data that we can look at, and then you have aggregated populations, it's a really good solution.
Yep, those are real dollars there. So, okay, so my time is almost done here. We'll finish up with a couple audience polls, and then I'll have Clint come back up. So this is just on what we just talked about. What do you think is the biggest perk of a direct primary care model? So didn't spend a whole lot of time talking about it, but we definitely hit the high points on it. So ability to focus on patient care, less paperwork, autonomy over practice, it affords better work-life balance. And this is, it could be answered almost by the doctor itself too, because there's compensation on there or all of the above. So the doctors like it too, because they can be more focused and they can be, it's not like they're taking a pay cut doing this, but it helps the doctors out and it can help the employer group out. I like that answer. All of the above, and then coming in second there is ability to focus on patient care, which is a very crucial part of it. What about the biggest drawback? So a doctor could look at this and say, yeah, less compensation. There's a cost perspective from a patient level. Too much work to set up. That's probably more geared towards the employer side of things, because it's not like you just flip a switch and it's all of a sudden there. So there's definitely drawbacks of it, but those are a couple of the initial and usual pushbacks within something like that. All the above, but patients to participate in it. That's a valid concern. Most misunderstood idea about the direct primary care model. So there's thoughts out there that it because you're maybe spending more time with the doctor, it's more expensive than traditional insurance. There's that concern that the specialist might be out of reach. So a lot of times your primary care physician is a part of a larger organization where they can refer you to someone else within that organization. Tests and procedures aren't included, or that's a concern that they won't. It sounds nice, but maybe the doctor is less available, and then only for wealthy or high income earners. Oh shoot, it was all the above. Sorry about that. I clicked way too fast. I can't go back, but it was all the above. From the split second that I saw it, there was maybe a couple other answers within there. This one's pretty important, and it just kind of is our takeaway. So again, a lot of info going against national. It's more important to look at the ICR and definitely dig into it a little bit deeper as you're going through your strategy. But what is your main takeaway from today? It could be strategies to better business practices, information about healthcare costs, ways to increase employee attraction and retention, self-funding information, and don't feel bad if it's number 5. Sometimes that's needed. It's wellness, right? So we'll get that poll, and I think that does it for me. Okay, information about healthcare costs. So good. Okay, I lied. One more quick question. Future seminars, what would you like to hear about? Compliance, communication to employees, non-traditional approaches, so maybe more of that, progressive employer strategies, wellness, or RX management. This will help as we plan for next year. And again, really appreciate you taking the time and the effort to be here and take the survey. Wow, we got a lot to cover next year. Okay, so it looks like the winner there is progressive employer strategies, but some close second and third there.
Which is, Samantha, that's our February seminar, something like that?
Okay, see if I can do this right.
February 12th. All right, February 12th. Already there. You knew what you were going to say.
So Clint, when you're done with this,
Yeah.
please don't exit.
I'm not going to touch anything. You
Okay.
gotta hit.
What's the prompt on that? That thing's blocking it.
I think you have to hit that. And then cancel. Yeah, just hit slide.
Okay,
Thanks.
thank you very much.
Really appreciate it. So I'm just going to take a few minutes, maybe 10 minutes, and tie this all together and explain how you can take that information. First off, thanks to JD. Secondly, he offered it many times. I want to clarify. So you guys get a report today. There's another report with like 40 pages that is available that we're happy to provide to you. We also have all this data dynamically. So if you would, we can't give you a passcode to that system. That's not in our agreement with you, but we're happy to schedule a meeting and come out and sit behind your desk or put it up on a screen in your conference room and rip through all these things and give you some insight and ideas behind it. So I'm gonna just kind of talk about what we do with our clients with the data that's available and give you some, we want you to walk away here with some takeaways. So give you some ideas of thoughts that you can have and how you can process it. So one of the things that we believe passionately about is that average is unimpressive, uncreative, and unsustainable. And so let me tell you what average is. According to Aon Hewitt, average is a 5% increase in employer contribution at the expense of an 8% increase to employees. That 8% increase is a combination of the red and the green. So that would be increase in out-of-pocket cost sharing and employee contributions. So that's what our country has done for the last 10 years. So if you took your benefit plans and modeled it the same way and did the same equations, what would you be? And that's, by the way, that's after the best consulting in the world. Right? That's after all of us in this industry are doing everything we can to help you meet your achievements. This is the result. So we actually took the historical information from Milliman. One of the reasons we partner them, interestingly enough, if I look back in the last 5 years within Milliman, now whether it's luck of the draw because it's Milliman or because it's some of the quality they bring to the table, their average employer cost is going up 2%. The employees are 3x that, but only 6%. And then over to the right is I just grabbed, some of these are slides that we just grabbed out of client material. So over to the right, we profile it against some of our clients to give them some perspective on how they compare, really do the work for them. So we believe outcomes are by design. We absolutely believe it. We believe it passionately. We believe that you can take a strategy, you can define what you want to do, you can set up principles, you can come up with implementation tools, resources, a way to affect it, right? So you need to understand direct primary care. You need to understand prescription carve-outs. You need to understand the impact of people. If I say, we're not going to let you have any albuterol and Harrow, or we're only going to go to one, and that you're going to save $400 per employee per year, what's the impact on those people? What does it do? But we also have seen and have validated that if you do that, this is a client, they have a 0.5% average annual increase over the last 8 years, and they didn't do it on the backs of their employees, right? Their employees had a 3% increase. A little bit of a difference, but way below some of the normative numbers we're looking at. This is a client that took every single recommendation we gave them, every single one. And we meet with executive councils, we meet with their board, we do employee surveys, we do focus groups, and we help them understand that this is an employer that's committed to benefits, they have a defined expectation of what their benefits are, and we go out and validate it and use data to validate that the company is defining benefits based on what their goals are, and then we communicate it back to their employees so there's a set of expectations. So one of the things that we'd say, if you have one takeaway today, is have a benefit strategy. Right, so let me give you an example. New hire comes in, this is a must-hire person, right? They're in your HR, they're going through it, you've identified them as a key person. How are their benefits? What's your benefit package like? Right, so how many people say, we offer a really competitive benefit package that covers all the major issues, and we have wellness and medical and dental and life and disability, and we're really proud of our benefit package, right? So I get that response all the time. So what if that same benefit package, and your explanation was this? We're committed to making sure that the single employee is in the top 75th percentile for our industry, and the dependents get the 50th percentile nationally. We also have designed our benefit program so that if you take action with AMA recommended advice as it relates to diet, exercise, and preventive care, that you get the lowest cost available. Right? Could be the exact same benefit package, I described it totally different. But it takes some planning to get there. So we believe that there's value in being able to articulate your strategy, use it as a filter for making decisions, and at the end of the day, you can articulate it in a way that you can tell your board and a new hire. So a couple of questions you'll want to ask yourself, and do all this before you start looking at benchmark data, because benchmark data is great, but if you don't have a plan, you'll end up just driving to the median, and it might not be the right thing, right? So what do you want or need your benefits to do? So here's 3 different answers that we get when we sit down with strategic executives of clients. So one might be, listen, we're happy to make sure our benefits are adequate. We don't want it to be a reason people join us, and we don't want to lose people because of it. But we're really happy to be adequate, right? Another one might be, our benefits really, we're not worried about comparing to national averages. I mean, we'd like to know, but we're not going to drive. That's not going to be a driver for us. We have our own culture, and our benefits are going to be a reflection of our culture. We might have a culture that says, we're going to hire really young people, and we're really yucky because our average employee is 24 and they stay on their parents' plan, right? Or we have $3,000 medical costs because, they're just not incurring a lot of claims. And then we often be a significant part of attraction and retention puzzle. We pay below market, and we're going to have above market benefits, right? So have a sense of where you are in that spectrum. Another question which relates to behavior changes because of how you design your benefits is how much responsibility and accountability do you want employees to have? It varies from employees' responsibility only, right? You've got to take these steps before we engage. We're going to give you tools, resources, and education, and then we're out. Another one might be shared responsibility, right? We're going to give you tools, resources, education. We expect you to take the following steps, and if it doesn't work, if you go in the black hole, if you had a colonoscopy and it was supposed to be free and you got a $750 bill and you called the line and it didn't work out, come to us, we'll help you. We understand there's black holes in the system. And then the final one is we'll take care of you. Call us for everything. Right? And think about that both on a customer service, employee service basis, but also plan design basis. What did I do? And then a final element is who do you want to be compared to? So we can come in and we can look at industry, national, region, and define it, right? So we have clients that are peer-oriented. They have a list, and this database isn't peer, right? We go out and we get specific information and we get peers. A common one is industry and then also region, right? Because a lot of times spouses don't work in your industry, right? So it's a really good idea when you're looking at opt-out credits or spouse employee contribution to have a sense of what the benchmark is within your region because it isn't always industry specific. Depends on the industry, really. Now, this gives you an idea of how to kind of segregate different benefits and where you might want to be, right? So we would say, we challenge you to say, a most prevalent plan is this concept of how many people are enrolled, right? So Milliman does a great job of telling me how many plans are there, but there isn't a lot of data in there that tells me which one are most people enrolled in. which will actually end up driving cost, right? So there's this idea of most prevalent plan, which is the one everybody's enrolled in, and then there's lowest cost plan. Have an idea, how do you want to benchmark? We would absolutely encourage you to segregate between single and dependent, if only because that's what the market does. So do I want to be median? Okay, my next question is, do you want to be median for single and median for dependents, or do you have a variance there? I've never met a CEO of a for-profit company that has denied the fact that they can't run their company with a bunch of single people. So there's if you take the cost of benefits and divide it by hourly productive wage rate, you know, dependents cost more. What's your value proposition? I'm agnostic in it, but just if there's a value proposition there, have it, take advantage of it. And then we would carve out dental, life, and disability and say, you know, the trend is actually to not support it at the same level. The trend is to say, we're going to embrace medical with all the available dollars we can, and we might do it at the expense of some of these others. So we might be in the top quartile in the medical and really okay that we're in the bottom quartile on dental, life, disability, vision because we can make it voluntary. So other areas that you would scrutinize, take a look at your enrollment, take a look at your enrollment trends. Couple of benchmarks. If you take enrolled and divide it by eligible, and it's under 80%, be able to understand why. Right? Is it because you have a lot of young people that are on their parents' plan? But that's basically the threshold, right? If you have relatively between the 25th and the 75th percentile in value of employee benefits, you're going to have about a 20% opt-out. If you have a 10% opt-out, I guarantee you have rich benefits. I don't even need to look at it, right? And so we can actually give you a cost associated with that. You know, here's the value. How do you measure that extra cost? How do you know that that's the right way to spend that money for your organization? Another one is single to total of enrolled. We generally see about 50% single, right? If you have 30% single and 70% dependents, you probably have really rich dependent benefits. And our question is going to be, do you get value out of that? Is that the right way to spend the extra money? So, you know, low dependent contribution is high dependent enrollment. It's above average cost per employee. It's okay. We have clients that have that. We have this discussion. We talk to them about it. They get it. It's fine. There's no judgment on it. Just understand it. So, at the end of the day, this is, again, just a couple of samples that we pulled out of some client information. We would come up with goals for our client. We'd segregate them in a couple of areas: cost containment, innovative solution, increased perceived value, compliance mitigation, administration, and technology. Not too dissimilar to some of the questions JD was asking. And then once we have a client establish goals, we would come up with a strategy. So where it's hidden up there, it says strategy. So not by accident, if you look at increased value, you'll see that we're doing some benchmarking. And one of the things for this particular client that jumped out was they had some awkwardness in how they were doing their cost sharing that related to two things. It not only related to the competitiveness of their benefit plan, where they wanted to be, but it also related into a scenario where they had a tremendously high enrollment in the least effective, most costly plan, and they weren't getting the value out of it. So, same concept, shown a different way. This would be a sample benefit strategy. Again, just out of a, this is actually right out of a client material. So you can see on the left, this is this organization's idea of where their statement of strategy, right? So benefits are going to be competitive. Single for the industry, dependents are going to be national averages. They're going to offer choice. They embrace this idea that those who consume more benefit dollars are going to pay a greater portion of the increase. And then on the right are some of the action steps that they took that implemented some of those strategies that they came up with. And at the end of the day, in the bottom right, this particular client has had an average annual cost increase per employee per year of 1.5%, and they were also voted one of the best places to work in their state. So, any questions? I went through that really quickly by intention because I just wanted to give you a flavor of some of the questions you can ask yourself. Any questions for our folks at Milliman? Any ideas, any thoughts? Wow. Yes? Yeah, I would say this. We have very few clients that don't have those. I would also say that the idea that consumer-driven healthcare was going to have people have their skin in the game long enough that they were going to ask providers questions and providers in the marketplace was going to respond hasn't yet achieved. So we're actually doing things, taking it to the next level where we're a big fan of a coordination of care model where you provide a before claim is incurred service model to assist people in managing the healthcare system. They might be in a high deductible health plan. They might have some employer funding to offset that. And then that person will do some of the work that JD and identify those different service areas, you know, booking an MRI for Clint for his bad back, but they'll take the time to find the lowest cost provider that's also within 5 miles of my house. So we're seeing a lot of effectiveness in that. It works really well if you're an employer that's willing to invest up front for the downturn. But I think high deductible health plans and tax favored accounts are here to stay. I'm a big fan. I'm hoping our government raises the limits on it and makes them a little less restrictive. And from an employer standpoint, you just get purchasing efficiency, right? So you're not paying a 20% premium load. You're just giving dollars direct to an employee. So I don't show hands from Pentra. Do we have clients that don't have those? I mean, if they do, it's because they've chosen not to. Yeah. Yep. The one thing that I would say is, depending on your turnover, the corporations and the employers that have gone 100% high deductible health plan, they get into end of fourth quarter hiring issues, right? So if it's more important to bring a new hire in, if you have a $3,000 deductible that starts again on January 1st, it's really hard to get somebody to start on November 1st. They end up deferring it. So we like a technique of at least an alternative plan that maybe isn't priced that effectively, but is it's a good kind of bullpen to put somebody in to hire them on 10/1 so that they only have 3 or 4 months of high contributions before their deductible reset. So we see things like that kind of in the maturity of the market. Yes? Absolutely. We actually do it dramatically more subtly than that. So employees want something different than employers want, right? Employees want a sense of quality. They might want parking. They might want cleanliness of waiting room. They might want immediate care. They might want coordination with their pharmacy. And so what we found is organizations that are built to serve those employee needs, and then we pump data to that call center folk and encourage the employee to use them to book their appointments. And then in the back end, they help manage that care in a much more cost-effective way. This isn't a new concept. The Fortune 100's been doing it for 15 years, and they have an incredibly low trend rate. So one of the things we've done is we've gone out and gotten some of those vendors to bring it down market to a 200 life group when they might have a 5,000 life minimum. It depends on where your claims are. So if your claims are all specialty pharma, no. It's not sort of a blanket recommendation, but if you have higher than average claims, yes, it's expensive. So you're taking $1.50 out of your TPA admin fee for call center, and we're adding 28 because we're putting a nurse on the other end of the line now. And by the way, the insurers are starting to do this too. Cigna has one that they're rolling out now. We're typically pretty big fans of going, a lot of the techniques that JD's talking about requires an independent TPA, right? I'm a little frustrated that our insurance companies aren't building this quicker because they could if they wanted to. So what we're having to do is go to independent TPAs, still access the network, and then layer on direct primary care. We're going to carve out prescription separately. We're going to put in a separate call center that better meets your needs. But yeah. I can talk forever. We can let you go. I mean, I will just talk. Any other questions? Well, thank you so much for coming. And Samantha.
We're going to actually do a raffle
Awesome.
for anyone who brought a guest today or interested in a gift card. We will be doing this for all future events, so note that. Clint, will you kindly take the gift card
I
out?
can't take the pressure.
All right. Will you take the gift
I'll
card
take the
out
gift
for
card
me?
out. Somebody else pick.
All right. Gordon, will you do the honors? Close your eyes. You can look. All right. Read it out loud.
Connie Mancini.
All right, Connie. Thank you. Where are you at? All right, and if you'll take 1 minute to fill out the evaluations in the folder that you have, it's on the right-hand side. And then I also stashed in there a calendar of future events. We have Clint speaking again on February 12th of 2019. And yes, for about progressive employer approaches. We have Rachel Druckenmiller speaking on wellness on April 10th. And then we have our next upcoming one will be to be determined. I'm getting there. Thank you so much for coming. What? Oh, and also, sorry, I'm new to public speaking. We have a client and friend meeting, holiday reception on December 5th at the new Terrain in Devon Yards. So you're all invited. I'll be sending out more information. And thank you all for coming.